Thank you very much again for joining this wonderful evening. Brendos, the Breast and Endocrine Society of Western UP, is once again in front of you with a new topic, a new, very important topic, very pertinent for our community. For those who are new to this program, Breast and Endocrine Surgery, this Brendos is the Breast and Endocrine Society of Western UP. Since I practice in Western Uttar Pradesh, I am the first and the only breast and endocrine surgeon in Western Uttar Pradesh, and I took the initiative to start this program here in Meerut. But it involves all the surgeons or any other specialist who have a keen interest in breast and endocrinology. They are the part of this program, and we have our meetings on every last Friday of the month at 7 p.m. where we pick a topic and we discuss about that topic in detail to get more informed about our community. We have a breast meet on every even month and endocrine meet on every odd month. September being an odd month, this month we have a very interesting topic, a very important and a much awaited topic, that is the medico-legal aspects in breast and endocrine surgery. Friends, we all know medico-legal litigations have risen multiple fold in the last few years. What are the various reasons? What happened which led to the change of this godlike image of a doctor and a patient to a consumer and a service provider like image? Are we really a victim, or we are negligent, or we are a combination? What are the various areas of fallacies? What are the various areas which we should take care of so that we don't fall into this trap? We, the breast and endocrine surgeon, most of the time we don't deal with emergencies. So are we really exempt from getting any medical legal liability? Or we are liable, but we don't know about? So what are the various areas which we as a breast and endocrine surgeon must take care of? And how should we prevent ourselves from these medical legal litigations? All these we are going to discuss in today's forum. And I'm so much delighted, I'm humbled, I'm honored that I have three surgeons with an expertise in medical legal issues with us today as faculties, as moderators. And I would like to introduce Dr. A.S. Jaggi sir. Dr. A.S. Jaggi sir is a general surgeon of high repute in our community, a very great personality, so humble, so ground to earth. He's MS in general surgery and did his fellowship from Sir Gangaram Hospital in hepatobiliary and liver transplant surgery. He did his FCCS in critical care and DHM from National Institute of Health and Family Welfare. He did his CCML in medical law, and he's a past executive editor, Journal of Emilia, that is Indian Society of Medico-Legal Allegations. He's an executive member of Indian Medico-Legal and Ethics Association, and he's a section editor, textbook of medico-legal issues. And as already told, he is a very renowned surgeon of Meerut and Western Uttar Pradesh. Another important personality that we have today is Dr. Rishi Bhatia sir. He's a surgeon of very great repute, very honored and very humble personality. He is a general surgeon as such, but he did his LLB and PGD MLE in D Pharma and DHM. So he did LLB also, following few interesting incidences that happened in his life, but it changed his perception towards his profession forever. And now he is the leading one in our community to give any medico-legal advice. And we are very honored, and we have an opportunity to get access to him every time. He's a past national president of Indian Medico-Legal and Ethics Association, and he's always pioneered in organizing any forum related to medico-legal issues. And for those who may not be knowing him by face, this is to introduce Dr. A.S. Jaggi sir and Dr. Rishi Bhatia sir. They are the brainchild of this medico-legal group that we all are part of. It's a pan-India, in fact worldwide, people are attached to this group, and they are benefited by the various posts that are being shared in that group. So they are the one who always keep a check that no non-medical legal related issues are ever shared on that group, and we have a fruitful discussion. So now, not taking much time, may I request Rishi Bhatia sir and Jagdi sir to take over and proceed with the further program.
Thank you, Dr. Sudhi, for your very, very kind words. They were a bit too much. Thank you
No,
so
no,
much.
no, no, no. So you all deserve, sir. You both deserve the same.
Thank you so much. Now, I'm honored to be a part of your conference, this webinar, and uh, I'm glad that the awareness of these medical legal issues is now coming up in all doctors, and that I realized when in 1 month I had more than 1,000 members in my medical legal group, right from say Kashmir to Puducherry. We have members in that group. So now this shows that everyone is now very much into this medical legal because they are facing day-to-day problems, and medical legal issues have now increased to almost 400 times what was 10 years ago. And that's how I was very much interested to join this conference. Thank you very much. Now, I have the honor to introduce our guest speaker, Dr. Sunil Khatri. Sunil Khatri is the founding partner of the law firm. He has nearly 40 years of experience in this field of medical law. He is an alumnus of Armed College, Pune and Pune University, and from where he obtained his MBBS and MS in general surgery and did his LLB, that is, he became a law graduate from the University of Delhi. Dr. Sunil Khatri runs a firm by the name of Dr. Sunil Khatri and Associates, and they are very expert in filing and defending medical legal cases. They also take up medical negligence compensation cases, also give consultation and assistance for altruistic surrogacy cases. I have really the honor to welcome him, and I'm happy that he's there with us now and will be giving his deliberation. Before he starts his deliberation, ask Dr. Rishi Bhatia to give his inaugural comments and any instructions which he wants to give it to us. Thank you.
Sudhi, for giving a nice introduction. I'm really highly obliged to opportunity to interact on this very important session. Actually, medical legal cases are rising day by day, but I'm very sorry to say that doctors are not getting aware. Consumers, means patients, are getting more and more aware, but doctors are not getting aware. So there, I felt need of awareness. That's why we created a WhatsApp group for medical legal friends to make awareness amongst the doctors. Earlier, in Consumer Protection Act, the litigations were filed at the place where the treatment was given. Now the change has been there. The patient can file litigation from any area of India where the office of the litigant is there or patient resides there. And moreover, earlier the litigation was based on the compensation demanded. Now the litigation is on the basis of what has been paid for the services. Moreover, the facility of online litigation is there and patients are free to file litigation online. These are small reasons which will increase the litigation more and more on the doctors. So the need of the time is that doctors should become more and more aware. The reasons for litigations are many. One litigation is infrastructure. The doctors used to give treatment or operate anywhere irrespective of the infrastructure. Second is the topic of today is what qualification you are having to do the treatment or surgery. Third is your competency. Competency is not only your caliber to do the surgery, it is what facilities you are having, what is the competency of your assistant, what are the armamentarium given to you. These all are determined competency. Today's topic will be very much interesting and giving the knowledge about the medical legal aspect of the endocrine and breast surgery. So I wish all should participate in it. The questions should be raised in the chat box relevant to the breast and endocrine surgery topic of the day, and other medical legal questions will be answered later on if the time permit. So I wish that webinar will be beneficial to all. Thanks you.
Is there that all the participants who are not speaking or hearing should mute so that there is no interference. And now I invite Dr. Sunil Khatri to give his wonderful deliberation. Thank you. Please unmute yourself, Dr. Khatri. Please unmute yourself.
Uh, Good evening to all participants and esteemed panel members. It is indeed my proud privilege to be participating in such a wonderful conference with a galaxy of eminent doctors and legal luminaries. I have heard Dr. Rishi and also Dr. Saab, Dr. Jaggi, that the way things have evolved, it is indeed true. I've been a surgeon for long years in my career. What is that? What are the events which prompted me to look for some alternate opportunities? Way back in the mid 90s, the situation was such that doctors were being arrested on frivolous grounds of FIR. If the bill was high, people would file an FIR. If the patient died, FIRs were being filed. And the emotionally surcharged relatives would be able to be influence the law enforcing agencies, and the law enforcing agencies also themselves would take the easier option to assuage the emotionally surcharged family members of the deceased that doctors were arrested. Before any judgment could ever be passed over the next couple of years, the doctor's image already gets tarnished. So these were the factors which prompted me. What can I do for the situation? That is what prompted me to do law. And after that, in Delhi, a situation came when the administrator of a hospital was arrested on grounds that a patient had abdominal trauma and he died on the way to the government hospital trauma center. The whole of Delhi state was up in arms. There was a complete paralysis of the medical facilities till I, senior members of the profession, came to the Lieutenant Governor. We formulated a policy that no doctor shall be arrested unless a medical board states that the events which have led to the demise of a patient or any other situation is akin to criminality. So that was a major step which happened way back in the year 2000, 2001. That further paved the way for the Jacob Matthew judgment in 2005, where I was fortunate to assess the Honorable Supreme Court, and when it was decided that no FIR shall be lodged against a doctor unless a medical board, preferably comprising of a set of government doctors who are from the relevant field of specialty, would say that there was negligence or an element of criminality. So I wanted to give you a little brief background that how did it all start insofar as I was concerned, and its impact, which the impact has happened on the profession. Now I would place before the August gathering that now in consumer courts, almost 30 to 35% of litigations relate to medical negligence. The options before a consumer are: A, civil litigation to seek compensation in the consumer courts; B, one can file a criminal complaint, although of course, as I have earlier mentioned, that arrest would not happen, though. So there is a protective mechanism which is in existence. And the third option which a consumer has is to file a case in the professional body, that is the medical council of the respective state, for professional misconduct. So these are the various options. I mean, smaller ones are like Human Rights Commission, etc. A consumer can seek relief. So we as medical professionals have to be careful that such situations can arise. Now, with this little background, I would request Dr. Saab, Dr. Kamboj, to start my slide presentation. May I request for the first slide? Thankfully, being already addressed And I've also tried to explain that what is the background, how did things happen. Next one, please. Next slide, please. Yeah. So my today's talk would be on ethics, morality, medical laws, its interface and interplay. When we talk of medical ethics, there are three concepts which are applied. One is thou shalt do no harm, thou shalt act in good faith, and thou shalt act in the best interest of the patient. Next one, please. Let us start looking at the history of medical malpractice. In 1754 BC, we have heard often that there was a code of Hammurabi, which was in the Islamic world. The code said that the doctor should be punished if he makes a mistake and that mistake causes harm to the patient. Next one, please. Subsequent to that, in the 5th century BC, the Hippocratic Oath, which we are so familiar with, was enunciated, and this was started in Greece. The essence is that shall cause no harm. Well, when did the first case of medical malpractice ever get recorded? As we go through the records, it is in 1374 in the Stratton versus Swanlund case. That was the first case of medical malpractice. I am very briefly touching upon this. We will not have a larger discussion. A surgeon tried to repair a woman's mangled hand. The deformity continued. This case was filed but was dismissed by the judge on grounds of procedure. However, the judge said that the doctor could have been held liable when they are negligent and would not be liable just because the patient didn't get cured. So it's a very important judgment which came about, that it is not always an outcome of a situation which should worry us, as long as we have followed the standard of practice and have provided due care which was due to the patient. Next one, please. In the next 30 years, there was a large increase in medical malpractice cases. This is just a matter of information and record. Now we fast forward the whole thing. In the 1980s in US, there were two resident doctors who treated a patient at night. The condition of the patient worsened and the patient unfortunately died. The patient father sued the doctors, and he also established that the doctors were overworked. He won the case. But this brought about a very major change, and this is extremely relevant in India. Although there is no such law in India, because our doctors in government hospitals and otherwise also are extremely overworked. So the New York State passed a law which defined the number of hours a resident or a doctor could work. Next one, please. Now, just to give you some statistical perspective, 6% of doctors are held responsible for 60% of all malpractice payments. In the United States, the total malpractice cost runs into about $55 billion. This was roughly about 6 years ago. These are the data 6 years ago. And surgical errors are the leading cause for claims from inpatient incidents. Next one, please. Now, let's talk a bit about Indian context. Most of our doctors are familiar with this, that when the Consumer Protection Act was notified, doctors were not included. It is subsequently, a case was filed by the Indian Medical Association versus BP Shanta, which was decided by the Supreme Court in 1995. And very, very eminent lawyers defended the doctor's cause, including Shri Harish Salve. But the Supreme Court did not agree, and doctors were included in the Consumer Protection Act because it was a service and fees were being charged by the doctors. Hence, this was included, and that was a major turning point in the professional realms and also for the consumer. Next one, please. Yeah. So, ethics is a set of morals which has been created by the profession. So, if you really ask me, it's a self-inflicted kind of a thing. Whether we call it self-inflicted injury, but then since we are professionals, so we had to define a code of ethics. And insofar as India is concerned, the Code of Etiquette Ethics 2002 still hold good, which were notified by the Medical Council of India. And I'm sure many of us know that last month, in the month of August, the National Medical Commission and the Ethics Board had notified certain code of ethics which were superseding the previous one. But then it created a very sharp reaction from the profession. And there were a couple of things in that. I mean, may I mention that, or you are all aware of it?
Sir, please explain in
Yeah,
detail.
I try to explain. So one issue related to funding of conferences, that the conferences shall not be funded. Now that created a sharp response from the medical profession. And the Minister of Health was very kind. He was willing to listen to the profession and gave a very patient hearing within a couple of days of the notification. And the second issue pertained to generic drugs. So it was mandated by the National Medical that you shall prescribe generic drugs. So that also created a sharp response, because there are many issues relating to medical drugs, generic drugs, and which will enlarge the scope of this discussion enormously. So on these two issues, the minister heard the profession, and those notifications have been held in abeyance. So complete code of etiquette ethics, which was notified in 2023 August, has been held in abeyance, and we are back again to the 2002 notification. That was just as a part of the mention today. So ethics, as I said, is a set of morals which have been created by the profession ourselves. Ethics has something to do with our conscience. It is a code of conduct. It is the way we behave. It's a way of life. And for all practical purposes, the word ethical and morals are interchangeable. The oldest code of ethics was the Hippocratic Oath, as we all know, and we talk about it very often. But it was a basis of a self-inflicted code of conduct. Next one, please. Now we say, what is morality? Morality is what people believe to be right and good, while ethics is a critical reflection about morality. Morality may vary in different cultures. For instance, abortion is not permitted in a Roman Catholic country and many other countries, but it is permitted in India and many other countries. So the morality, and it varies from culture to culture. Now, laws are notified for the welfare of the society, to resolve conflicts.
Next slide, please.
Yeah, next slide, please. So what is law? Law is to protect the welfare of the society. It is there to resolve conflicts and is a constantly evolving situation. And please note, for all doctors, that we have no codified law. Now you will like to ask me, what is codified law? Like you have an Indian Penal Code which has got section so and so, so and so, and so and so. Medical law has no codification. It is based on judgments. As the judgments come about, they become the basis of law. The basis of law is very, very simple. It is doctor owed a duty of care. Second, there was a breach in performance of that duty. And the third is that harm came to the patient is when negligence gets established. So I reiterate, there is no codified law insofar as medical law is concerned. Laws are mandatory to which all citizens must adhere or risk civil or criminal liability. So we are. Accordingly, we are also liable for civil or criminal liability. Next one, please. It was a very interesting situation. What is the interplay between ethics and law? Ethics cannot be considered in isolation of law or vice versa. Ethics and law are cognate. That is to say, they are related to or descended from a common ancestor. So there is often an overlap between ethics and law. And we need to understand the dynamics between them. Next one, please. And the panelists may stop me at any stage if the panelists may so desire to. Now, ethics and law, are they complementing each other or they are conflicting each other? Let's examine this. There is no doubt that they are complementing. Historically, the code of conduct and code of ethics was self-inflicted. This is the third time I'm saying in my presentation. We asked for it and we did it ourselves. However, as the time passed by, and there are numerous scientific advancements and rapid industrialization, there was a massive change in social and cultural behavior of the people. The relations between physicians were wedged by several interacting forces: the politics, the government, the law, the media, etc. It became extremely necessary to frame a statutory framework which measures and enforces the principles laid down in the code of ethics, and that is how medical councils got. That is the basis of creation of medical. We are actually fortunate that we are here to self-regulate the profession. The power of the medical council is enormous. If there is a suspension of license, it is like a death sentence for a doctor. Next one, please. Now, what are the principles of ethics? Autonomy. As I have been mentioning to you on several times, it is the right to self-determine. It is a doctor can decide, because the matters are so technical, only he can decide, and he has the freedom to act independently. The issues in ethics are informed consent, the issues of confidentiality, patient confidentiality. I will tell you an incident where one of the most powerful family's grandson fell down from a swing, a झूला. एक झूले से वो बच्चा गिरा और दिल्ली में एक कॉर्पोरेट अस्पताल में वो बच्चा भर्ती हुआ. शाम के वक्त किसी मीडिया पर्सन ने अस्पताल को फोन किया और इस डिस्गाइज में कि साहब मैं उस पावरफुल फैमिली से बोल रहा हूँ और बच्चे की कंडीशन क्या है. The front office person got overwhelmed and he gave the updated status of health of that child. And you won't believe it, that most powerful family of the country filed a case of misconduct against the doctor and the hospital who were treating the child. And I was there in the Medical Council of Delhi. We had to decide. On one side was the pressure of the government, that the most powerful family has filed a complaint. On the other side was the profession. It was an unintended situation which happened. It is the front office who leaked the health data. So anyway, this was just an example to mention. Now, the principle of ethics also says beneficence and non-beneficence, which means you are acting in the best interest of the patient and thou shalt cause no harm. The justice is the principle that deals with fairness, it deals with equity, and it deals with equality. It is distributive, societal, it is on a comparative note. It is the link between ethics and law has been very, very nicely summed up. Law cannot reach where enforcement cannot follow. कानून वहीं तो हो सकता है जहां पे उसका enforcement हो सकता है. Which brings us, ethics begins where law cannot reach. To say that अगर कोई behavior ethical नहीं है, that is more powerful than the law. It is also important to note that ethical standards required of professional often exceed that of law. And we shall take up certain examples. Like the issue of advertising often comes. As per our 2002 Code of Ethics, advertising by doctors is not allowed. Thus, we have to understand that ethics tells us no. Ask me, illegal? Does it violate any law? Advertising does not violate any law at all. And if you see the advertisements of corporate hospitals, there is no check on that. The check is only on doctors. So what a situation that the doctor who's working in the hospital cannot advertise, but the hospital which is taking the services of the doctor, they are free to advertise and have large boards. Next one, please. Now, ethics again says that you shall not give cuts, commissions, and shall not solicit patients by giving gifts, etc., etc. But it is unethical. To divide the fees, to give a cut to the referring doctor is unethical and is liable for disciplinary action. But the law does not prevent that at all. There is no law which says you can't split fees. In fact, corporate hospitals in their P&L account will be sending payments to referring doctors, and no action can be taken against. Similarly is the issue of financial inducements, which we talked about. The pharmaceutical companies giving gifts giving travel benefits to doctors, their families, etc. So the code of ethics says that this is not permitted. And this is what was the issue which came about in the new notification. And various punishments have also been notified, from censure to even permanent deregistration in case of such violation. Now, come to the next one, please. Under the code of ethics, a medical practitioner gives a solemn declaration: I will maintain utmost respect for human life from the time of conception. Yet, the MTP Act permits us to terminate pregnancy. And this, of course, varies from geography to region. And same could be illegal and unethical in a country, say, for instance, Ireland, which is a Catholic country, but it is not so in India. So, in other words, an act could be illegal but ethical, and also, on the other hand, could be legal yet unethical, as we discussed in the case of advertising, soliciting patient, fee splitting, etc. Next one, please. Now, there are situations there is conflict between ethics and law. The medical code of ethics states unequivocally, in an operation which may result in sterility, the consent of wife and husband is mandatory. This is in direct conflict with the MTP Act, which emphasizes that a woman's right is supreme. The consent of the spouse is not essential at all. And in fact, strict confidentiality has to be maintained. We recall an incident in which, in a party, a doctor had casually mentioned to somebody that so and so's wife had undergone an MTP. And casually, that information was leaked and it was mentioned in a social gathering, and that created a huge issue in the family. So, what we are trying to say is that consent of a husband for MTP is not required in the law, but the code of ethics says such a procedure for sterilization or for vasectomy or tubectomy, the consent of the husband and wife is mandatory. So that's a conflict situation between ethics and law. Next one, please. Now, the question of informed consent. There was a case of one gynecologist who was dealing with a patient and she had endometriosis. So when she opened up the abdomen, she found that there is a need to do a hysterectomy, but the patient was under anesthesia and the patient could not give consent. So she came out, she was a very senior gynecologist in Delhi. She came out and asked the permission of the relatives who were there. The relatives said, please go ahead. The hysterectomy was performed. And when the patient woke from anesthesia, he was informed that you have had a hysterectomy. And the immediate question she asked was it my uterus or my relative's uterus? The doctor had no answer. This case went up to the Supreme Court, and the Supreme Court held that the doctor was wrong. Consent should have been taken. So when a patient is in sound mind and the procedure has to be a planned procedure, one must insist that the consent is taken from the patient. Very often I come across documents in which the consent is of the husband. Incorrect. The consent is of a father, of a relative. Incorrect. The doctor has to ensure that the consent is by the person who has to be operated, and it has to be an informed consent. Informed consent means that you shall explain all the possible scenarios which can emerge. I know it's a very tough call. It's a very tough call to say that 1% मौत का भी खतरा है. But then that's what the law expects us to do. That the consent should be informed and it should be of the person who is undergoing that treatment or procedure. Next one, please. Now, again, the real consent and informed consent is also an area of conflict. A distinction is made between real consent in the UK and informed consent in the USA. The judgment also quotes certain figures are given. We'll not talk about this, but this is an area which is full of ethico-legal uncertainties for a doctor who has to decide how much to tell the patient, because a 1% risk in general would be 100% risk for the patient who suffers that risk. That is the risk of death. That is the risk of, just giving you an example, 1 in 10,000 persons having a thiopentone sodium is likely to have a cardiac arrest. But if you don't explain to it, the person who sustains and the revival is not there and he goes into brain damage, for him it is 100%. Next one, please. Now, rapid advances in medicine, the mind-boggling advances in medicine and technology keep aggravating the dilemma of doctors and the society. And the margins between ethics and law become more and more hazy. And the common lineage between the become more evident. It is true that law is lagging behind the advances in medicine, but not having kept pace with the progress in medicine. Next one, please. Now, what are the legal and ethical challenges faced by healthcare providers due to rapid advances? Genetics, prenatal testing, organ donation, stem cell application, abortions, end of life issues. Now, end of life issue is a very, very big issue. Very, very big issue. Can you pull out the ventilator? No, you can. But if the patient party is not paying in a corporate hospital, you're gone. If you do not pull out, so it's a very, very tough call. Fortunately, the Supreme Court has very recently notified certain procedures for end of life issues, and that has come to some rescue. Otherwise, for people dealing with tertiary care, intensive care, and critical care, it was very, very tough decision. And more so when there are properties at stake, there are relatives living in the United States who have different views, and the people living in India, that is the family, they have different views. And such litigation often drag doctors. So end of life issues are a big issue for hospitals who are providing ventilatory support, who are providing critical care, and they create very, very painful predicaments for doctors. Next one, please. Ethics and law, interplay, non-supply of patient record. There was a judgment in which there was delay of 2 years in supplying documents. Now, the Honorable Court invoked the regulation of the IMC, 2002 regulations, which say that you have to supply the medical document within a period of 72 hours. And the court came down very heavily on these people who did not supply document for almost 2 years. So the dynamics between ethics and law get emphasized in this judgment. This was in the Supreme Court. So just to mention, I'm sure all of us are aware of this fact that the document should be supplied immediately on a written request when the patient party asks for it. Now, I've just talked about the right to die with dignity. This judgment was, notified, passed by the Supreme Court in 2018. It was an impossible judgment to implement. So the Constitutional Bench heard the matter again in 2022 and came out with a more practical suggestion. Anybody who wishes to know more about it can contact me offline. We can always assist in this matter. Next one. Well, after the lockdown, there was a quick notification of the telemedicine guidelines. We all are aware, and it was a commendable step to implement urgent requirement in a crisis. One has to be slightly aware that what are the drugs you cannot prescribe on telemedicine. I remember correctly that psychotropic drugs should not be prescribed, but this is again an interplay between ethics and law. Next one. Now, the various landmark judgments, some of which we have talked about. We have talked about Indian Medical Association versus VP Shanta, which brought doctors into the consumer protection. Then there's a Jacob Matthew judgment, which was a landmark judgment in 2005, which still holds good, that doctors cannot be charged for criminality. No FIR can be lodged against doctors without the opinion of a medical board, preferably government board, which comprises of specialists from the relevant field of speciality. So in smaller towns, tier 2 towns, when the IO tries to boss over you, he tries to say, hum arrest karenge, paise do, ye do, then you can always look back and give reference of the Supreme Court judgment of Jacob Matthew. And there are other judgments like Lalita Kumar, in which doctors have been placed in a very separate position, that no arrest of the doctor, no FIR can be lodged without a medical board. And also, no lady can be called to the police station for interrogation. They have to come to the lady doctor, to her place of work, and no interrogation. So please be mindful of that. You can circulate it amongst the members. Now, there are two other judgments which we are referring to: Martin D'Souza versus Mohammed Ishfaq, in which the judgment was that a medical board is mandatorily required for establishing negligence. This was overturned in the very next year in VK Christian Rao versus Nikhil Super Speciality Hospital. It said that every case cannot be a kind of a straight jacket, that it has to be referred for opinion of a medical board. It is the discretion of the judge. There are cases where the judge cannot decide, can himself decide. So the requirement of a medical board mandatorily were taken away. The Kunal Saha judgment, most of us are aware, this is the first case in which very large compensation was awarded by the Supreme Court, almost to the tune of 12 crores, out of which about 6 crores was the primary compensation and balance was the interest over it. This was for a lady who had some dermatological lesion in which steroid dipomedrol was given and she had died. The complainant was from the United States. He was very well informed and he very aggressively pursued the matter. And this is a landmark judgment which the medical profession must always be aware of. Now, just a little while ago, talked about the Samira Kohli judgment on consent. So that also we have to be very aware and be mindful of. Next one, please. Well, medical negligence, we try to say the medical malpractice litigation has evolved dramatically since way back of the Code of Hammurabi. There are certain principles which remain all the time. The responsibility of medical professionals to prevent unnecessary injury and death, this remains unchanged. The major controversy still surrounds how best to improve medical malpractice law and hospital culture so that medical professionals can truly focus on providing the best care to the patient. Next one, please. To my mind, the solution lies in alternate dispute resolution. Because you see, cases drag on for years. The moment a case is filed, the doctor as such has been penalized because he has to, fight this litigation for long years. The best option is alternate dispute resolution. Doctors should sit together and solve and be able to come at a quick solution so that the cases don't go on. Next one, please. Final question. Does ethics drive the law or does law drive ethics? Whatever the answer to this question, there is no doubt that there is a heightened need for medical ethics and law to be complementary as well as synergistic and have greater interface and interplay. So this was my brief presentation to the August gathering. I'll be open to any questions as and when the organizers and the panelists decide so. Thank you very much for your time, your attention, and the patience.
Okay, thank you very much for this enlightening talk, sir. And it really provided so many questions that we often discuss in our medical legal groups. And you gave a very good evidence-based uh, answers to all these questions. Now, sir, as we know that it's the Breast and Endocrine dedicated forum, so there are few important questions that now I will be taking. And I request now, since we have three important experts, those are surgeons, like they are related with the medical field, as well as they have a huge exposure of Indian laws and ethics. So I'm now putting those questions to you, and I will ask one by one, first from the guest faculty and then to our moderators, to please give their expert opinion regarding those conflicts that we often face in our day-to-day practice. So with this, now I'm again sharing my screen. There are few problem-based learning questions that I will be putting, and those I have clubbed into different categories. So our first category is when we manage refractory symptoms only. So there are incidences that I will be sharing where the symptoms were managed, those were refractory, but the physicians keep on managing those symptoms without evaluating the other possible causes of the symptom. And then what are the implications? So the case is of a 40-year-old male who had a recurrent nephrolithiasis, which required multiple interventions because of obstruction for past 10 years. So this patient then developed chronic urinary tract infection. Not only that, while having a procedure done in 2015, PCNL, percutaneous nephrolithotomy, he developed pyelonephritis, iatrogenic infection in his kidney, because of which then he developed a chronic renal failure. Incidentally detected to have hypercalcemia during workup at some tertiary care referral center in 2019. That is after 4 years of developing this pyelonephritis. And that workup then confirmed that the patient had primary hyperparathyroidism with a lesion localized to right inferior parathyroid. So this patient was a case of primary hyperparathyroidism which remained undiagnosed for past many years, and the urologist kept on just removing the stones but not working that patient for the real causes of this recurrent nephrolithiasis. Another case is of a 46-year-old female. She was married but bedridden for past 5 years because of generalized bony weakness and multiple pathological fractures. So every time she used to visit to her orthopedic surgeon, what she got used to get was vitamin D and calcium supplementation and fracture fixation. Because of the prolonged recumbency, she developed depression, and she consulted some other orthopedic surgeon for a second opinion, where by chance that orthopedic surgeon diagnosed hypercalcemia and then referred to endocrinologist, which was then later on diagnosed as having primary hyperparathyroidism, and that lesion was then localized to the left superior parathyroid. Both the patients then had their surgeries and they had a partial recovery following that. But the thing is, we often see as an endocrine surgeon similar scenarios like patients with secondary hypertension, patient in their 20s having severe hypertension, episodic hypertension, but physicians they don't work up for the various causes of secondary hypertension, and pheochromocytomas are often missed in those cases. And many times these patients they develop some complications either in the form of intracranial hemorrhage or myocardial infarction or some peripheral infarctions, and they present to the emergency, and then most of the time these patients are diagnosed. Similarly, for resistant hypertension, we see that there are missed cons adenomas or recurrent hypoglycemia. These patients are often diagnosed as having some psychosomatic disorders, and we miss insulinoma. We never look for these. So the question is, now after the diagnosis is established in the it could be anywhere in the tertiary care referral center, some other physician, doctor, they have diagnosed. But if the permanent injury, the grievous injury is already happened to the patient because the patient was not worked up adequately, how prone are the previously treating doctors for litigations against not working up, hence missing the diagnosis, leading to grievous injuries and loss of functional life years? Sir, so first I would like to ask Sunil sir about his opinion, and then Sir Rishi sir and Jagdish sir also.
See, the well-established principle is error of judgment does not constitute negligence. Error of intention constitutes negligence. Second guiding principle is what a reasonable doctor could have done in the situation. Not the most experienced, not the topmost doctor could have done in that situation. So let us talk about the recurrent nephrolithiasis. Whether a reasonable doctor should think on the lines of parathyroid adenoma is the question which will decide this. And he is a urologist. If he has facility, you may not have facility of a endocrine surgeon in a particular place. So this may be to his benefit that he would be exempted. And as I said, that second is the error of judgment. He did not judge that this could be a parathyroid adenoma. I will go one more step, digressing from these cases. If a particular complication is a known complication, of a particular surgery and a patient unfortunately develops that complication, the defending doctor or his advocates, if they are able to establish it in the courts that this was a known complication. And I'll give you very specific examples. While doing a cholecystectomy, a very senior surgeon unfortunately injured the portal vein. Now, portal vein injuries during cholecystectomy are very, very rare. But because I had to defend a case of this nature, I studied through literature. And I came across that the topmost hepatobiliary surgeon from France, I'm not recalling his name at the moment, has also had 3 cases in his career that the portal vein injury happened. And portal vein injury is very, very difficult to repair. And in many instances, it is fatal. But if you are able to establish your case well, that this is a known complication, and what should have been done in a situation was done. For instance, in the particular case which I am dealing with, the surgery was performed in a tier 2 city. There was no help available which was more competent than the operating surgeon himself. So he tried to refer the patient to, I can use the place, Chandigarh. PGI Chandigarh, he established contact with the department. The department said, please send the patient straight away. He put the vascular clamps. He did the packing. He sent a doctor assistant along with the patient. The patient was resuscitated. She was not collapsed. Unfortunately, the patient party decided not to take the patient to PGI Chandigarh, and instead the ambulance were diverted to Mohali, one of the corporate hospitals, where another general surgeon attempted and the patient died. And I am defending this case. So I am reasonably sure that because of this known complication, I'll be able to defend. So it was a slight digression from what you had talked about, the parathyroid adenoma. So again, what a reasonable general surgeon or a reasonable urologist can think, that will what will decide, and what is available locally to him. So error of judgment is pardonable.
Okay. So, but if still, like suppose they have the facilities of endocrinologists and endocrine surgeons, and if there is widespreadly being advocated, like these could be the disorders, like they are not in a very remote places, they have access to endocrine surgeon, endocrinologist, but still if they don't think about it, like can the patient ever sue? He like, why did
Yes.
you
So
what
again, most of
this
the
way?
outcomes are based on facts and circumstances of the case. The patient has a case, he can sue, but then it is how well it is defended by the doctor and how well it is, presented by the patient party will determine the case. Again, case to case basis. But I have given you the guiding principle: error of intent, error of judgment, and standard of care. That is what a reasonable ordinary person could be doing. What an ordinary doctor could be doing in the circumstance is
Fine.
what determines.
Yes, sir. Rishi sir and Jaggi sir need your opinions as well.
Dr. Sunil has rightly pointed out that the judgment, if done wrong, cannot be punished for. He has also mentioned that the similarly qualified person, what would you have done in the same circumstances? We call it as a Ghulam test. The similarly qualified person would have done the same thing in the same situation, then it is not the negligence. One cannot do the same thing in the rural hospital, which can be done in a metro city or the corporate hospital. So the similarly qualified person in similar situation, if does the same thing, then it is not negligence. One thing. Second, we should not focus on the symptoms of our specialty. We should take help of the other specialty, super specialty, to go through the root cause of the different different cases. One should take the opinion of the endocrine surgeon, endocrinologist, if the facility is available in that town. So negligence is defined only on the basis of Bolam test. On the parameter Bolam test, then it is labeled as.
Fine, sir. Thank you very much. And sir, Jaggi sir, would you like to add something to you? Do you agree with what the both surgeons told, or you have some other opinion as well?
No, it's very clear that we see. I really pity that urologist. I pity that physician who missed an insulinoma, and that orthopedic surgeons who missed that parathyroid tumor. So I pity them. They have done something wrong. They shouldn't have, since they are also specialists. They will not be super specialists, but they are specialists and they should have thought about it. But we finally see whether the clinician deviated from the standard treatment. Did he use any wrong technique in giving the treatment? So the urologist, in his good intention, made the stone vanish, but it reappeared. So his intention is not bad. So the court sees whether the intention of that doctor was bad towards the patient or he was doing his normal duty. Similarly, you should handle those cases which are in your purview, in your expertise, in your experience. And if you feel that the urologist should have thought that since this patient is forming recurrent stones, has got in recurrent UTI, and now has gone into, say, chronic renal failure, he should have thought it earlier to refer the case to an endocrinologist to find out what was the cause. And then, of course, if there was something wrong with the parathyroid, the case should have gone to the endocrinologist, endocrine surgeon. But if the court sees into this scenario, I don't think that the doctor will be punished or penalized.
Fine.
That's what I want to say.
Yes, sir. Thank you very much. All your points are very valid. So, important takeaway, what I can understand, that if any patient is presenting with recurrent symptoms, same problem again, at least after 2 to 3 interventions, one must always think about some causes, some plausible causes, some root causes which they are not hitting till now. And for that, we need continuous medical education to know what is the upcoming thing, why the thing happens. For that, they people must take out time to find out, or they must take the help of some experts, some higher center, to understand ki what is happening, at least to save their skin at least. So that maybe in some educational institute they will find more answer, because they have more institutionalized work, they have more academics and more interdepartment discussion. So hopefully.
I would like to say one thing after you complete, Dr. Sudhi.
Yes, sir. So you can.
आप complete करिए तो I just want to say one sentence.
Question is कि if any patient, though it is not considered medical negligence, it could be very well defended, but in the best interest of the patient, if the patient is presenting again and again with the same problem, it is always good to take opinions from some higher center to know how in other way we can help this patient, so that the patient doesn't, or at least can establish a diagnosis of this recurrent stone formation, at least whether it is a curable or a non-curable condition.
Dr. Sudhi, I very well agree with what you say. The patients are very much educated, and I have seen patients asking me a question that why I'm forming this stone again and again, why my UTI is not subsiding. So you are very valid in saying that the clinician treating the patient should think. I hope many people are listening to this webinar, watching this webinar, and take a carry home message that, of course, if such scenario happens, they must refer to an endocrinologist, or if the cause is found, then to an endocrine surgeon.
At least they must establish the cause of this recurrent stone. That the important thing is why this is, because all the patient, they need answer, why am I having this problem again and again. So as an endocrine surgeon, we often face this problem. The patient tell ki we used to ask our urologist regarding ki why it is happening to me, and the answer was never told, but now that we know the answer, but it was never told by them for past many years. So this is the take-home message that I would like to ask our participants to take. Any patient with a recurrent problem, not healing, like presenting again and again with the same problem, especially recurrent renal stones, recurrent pathological fractures, then if at least establish the diagnosis of why this patient is having this problem with extensive, exhaustive workup, take the help of other experts as well, so that at least you rule out many other things. And if any correctable, curable cause is being detected, at least it will be helpful for the patient.
So, because I often deal with a large number of cases in which allegations are made, we are defending doctors and vice versa, and so on and so forth. A judge is entitled to make a wrong judgment. He may, how the case is presented and defended or the complainant party presents, because the judge is a man who has a clean slate. He has no knowledge. You have only gone to him for justice. If the pleadings are well done, you get a favorable judgment on either side. And yet, he is entitled to make a wrong judgment. I will give you an example of a patient who was a chronic alcoholic. He had well-established esophageal varices. He was a diabetic who was very bad in his habits. His blood sugar was never under control. Just because a doctor was treating him and he developed diabetic nephropathy for his own doings. But the case was presented by the son of the deceased, who was a lawyer. The doctors were held negligent. Now, all of us who know clinical medicine well understand that if a diabetic is there, his sugar levels are not controlled. He continues to have bad habits. He has alcoholic cirrhosis. He has esophageal varices. He will die because of these conditions. But the judgment was against the doctors. It was held in National Commission, and even the Supreme Court said that there are findings in the National Commission which are against. Now, all of us know what we are talking about, but unfortunately, the way it was presented. So, judges are entitled to give wrong judgments also, and you can do nothing about it. So, अपना ध्यान रखें और अच्छे से पैरवी करें जिससे कि things go right for you. But this point is very well said, that if there is a recurrent stone former, the clinician should raise a flag. Why is the patient forming stones again and again and again? Thank you very much.
Thank you very much. Now we move on to our next problem-based learning 2. So this is regarding cross-pathy. So friends, we know nothing is black and white in medicine. So we always have a gray zone. So there are illnesses which are being treated by other specialties. A similar problem is being treated by different specialties, and many a times they put their guard over it. It is their specialty. It is regarding case 1, who is a 46-year-old married female with completed family history, presented with a periductal mastitis induced periareolar abscess at 3 o'clock. So she had a periareolar abscess, left breast. Now she consulted a gynecologist who advised and executed an incision and drainage under general anesthesia with open dressings. So she did an incision drainage of this abscess, that she drained the abscess and started doing open dressing. But the wound remained unhealed, leading to chronic discharging sinus with recurrent abscess, same breast, but at 9 to 10 o'clock position, around in 1.5 to 2 months, though the problem remains unhealed. Now she consulted a breast surgeon. So she then underwent radical mammary duct excision with pan-quadrant drainage of all the abscesses, followed by vacuum-assisted dressing and then secondary suturing. Now, please understand case 2. Here, there was a 45-year-old female who presented with the right iliac fossa pain and referred to an endocrine surgeon for large right ovarian complex cystic lesion detected on USG abdomen. Her tumor markers were negative, and endocrine surgeon did an explorative laparoscopy with right ovarian cystectomy. The final histopathology was ovarian cyst adenocarcinoma. So the thing here is, the questions are, can the gynecologist, they can operate on breast lumps, breast cancers, breast abscesses. So we see the instances where we see the gynecologist operating on breast lump, cancers, breast abscesses, and even hemorrhoids. We see instances where general surgeons, oncosurgeons, endocrine surgeons, they operate on uterus and ovaries. The urologists, they operate on adrenals. So the question is, are these cross-pathies are absolutely contraindicated, or there is any minimum qualification required to undertake these procedures? Can any patient sue against the eligibility to conduct such procedures, and what are the remedial measures? Like, can any patient, suppose if there is any complication following any procedure, so can the patient then sue that particular doctor that you were not eligible to do the certain procedure, but you did, and because of that I am having the complication? So what is the minimum qualification? Like, suppose if surgeon, most of the time they have some amount of exposure to particular surgery. So is there any way they can defend, or it is absolutely contraindicated? The gynecologist must not operate on breast, the endocrine surgeon cannot operate on ovaries or uterus. These are your opinions, sir. Sunil, sir?
I would request Dr. Jaggi and Dr. Rishu to first take up this question, then I will request after them. I may like to permit. I hope the panelists will accept my request.
No.
Sure. Don't worry.
Sir,
Anyhow, they were supposed to answer. They can answer first.
as far as gynecologists are concerned, they can treat the disease which
Sir,
have
I'm
been
sorry to
caused to
interrupt, sir.
them.
Your voice is echoing, sir. So the participants may not be able to understand.
As far as gynecologists are concerned, they can treat the disease which have been taught to them in the syllabus of post-graduation, whether it is a degree or diploma. If they have not been taught, they cannot do. Breast is the entity of general surgeons or oncosurgeons. So the qualification of gynecologists is limited to their specialty. In Indian scenario, now MCI is thinking about that breast should be included in the course curriculum of postgraduate gynae because most of the ladies come with the breast problem to gynecologists. So till it is included in their course curriculum, they cannot operate on the breast. Number one. Number two.
Dr. Bhatia, I'll interrupt you. The question here is cross-pathies, whereas here I think it should be cross-speciality.
Sir, you can name it anyway. Like
No.
new term
We are all working in the same pathy, allopathy. So it should be cross-speciality.
maybe, sir.
That would be a better term at this part. Okay. Dr. Bhatia, please carry on.
Yes, I agree with Dr. Jaggi. When a modern medicine doctor prescribes homeopathic, Ayurvedic, then it is cross-pathy.
Yes.
If a general surgeon practice in a orthopedic field, then it is cross-specialty. So the terminology is the cross-specialty.
So
My number two, ovarian cyst can be operated by a gynecologist. In the second case, the gynecologist operated the ovarian cyst.
No, sir. It's endocrine surgeons. I'm talking about surgeons, whether they can operate on uterus or not. Uterus
No,
and ovaries.
surgeon cannot. Surgeon cannot. When a surgeon have to do a surgery on the uterus or ovary, then the case in charge should be the qualified gynecologist. Although gynecologist may not be operating, but surgeon may work as a assistant on the case sheet, and the operating surgeon would be gynecologist. Surgeon cannot do Caesar, surgeon cannot go for uterus surgery, surgeon cannot go for the ovarian cyst, except in life-threatening emergency. Only life-threatening emergency, for example, in Caesar. Caesar can be done if no gynecologist is available, then general surgeon can do Caesar.
Sir, Jaggi sir, want to add something?
Of course, there are many instances in my career where a gynecologist has called me, and many cases where I needed a gynecologist, and many instances where gynecologists refused the patient for the surgery and I operated. So I don't know how you will define yourself to the court of law, that whether you were required or whether the case was denied by the gynecologist, so I took up. So this is all will be evidence based. If the gynecologist writes down on its prescription that this is a complicated case and should be referred to a surgeon, and you have that paper with you, then you can go ahead and operate.
Okay, so sir, it's in this regard, there is one important question. Like during the general surgery training, surgeons often have a rotatory posting, which includes super specialty rotatory posting, which is there in the oncosurgery department also, where they have an exposure of hysterectomies regarding Vardymes and ovarian tumors and all. So those surgeons who already had an exposure, so are they also still barred from operating on ovaries and uterus despite having their exposure during general surgical training?
See, I had earlier mentioned that the doctor should have an expertise. With that, he should have an experience. If you can prove yourself that you are very much trained for doing that surgery, you can do it and you can defend yourself in the court of law.
Absolutely.
I think Dr. Khatri will.
I would now, whenever Dr. Jaggi concludes, I will then take up.
Yes, I have concluded, sir. Please come up.
Yeah. So I'll tell you, I'll be saying certain things which are sweeping also. The Medical Council of India erstwhile had an Indian medical register. Even now, the NMC has a Indian medical register, which is a compilation of all state medical registers. A very difficult situation has come about that people are being told you can do this and you can't do this. Please take my submission with due humbleness and due modesty. I am saying, where is the specialist register in India? Do you have a register of gastroenterologist? No. Do you have a separate register for oncosurgeon? No. There is a combined register from MBBS to MCH, from MBBS to DM cardiology. India comprises of Delhi, which has got intervention cardiologists. They have got specialists in electrophysiology, but there are tier 3 towns where none of these are available. So कहने का मेरा तात्पर्य ये है कि अमेरिका में एक स्पेशलाइज्ड रजिस्टर्स हैं, बोर्ड्स हैं जो रेगुलेट करते हैं कि कितने स्टूडेंट्स डिग्री हासिल करेंगे और उनका स्टैंडर्ड्स ऑफ केयर क्या होगा और क्या क्या प्रैक्टिस कर सकता है, क्या नहीं कर सकता. हर अस्पताल के अंदर क्रीडेंशियलिंग कमेटीज हैं. कोई एमएस जनरल सर्जरी लेके किसी अस्पताल में जाएगा अगर अमेरिका, तो क्रीडेंशियलिंग कमेटी डिसाइड करेगी कि वो क्या क्या कर सकता है, क्या उसके प्रिविलेजेस हैं. हिंदुस्तान में ऐसा कुछ नहीं है. मैं ये वास्तविकता आपके सामने प्लेस कर रहा हूँ और लीगली भी प्लेस कर रहा हूँ ये कि जब आपके पास स्पेशलिस्ट रजिस्टर नहीं है तो किस बात का ये विवाद. जो बात डॉक्टर जग्गी ने कही, ट्रेनिंग, वो सबसे अहम है. हम उसको थोड़ा सा आगे बढ़ा सकते हैं. क्वालिफिकेशंस एंड ट्रेनिंग. In Delhi, I have seen orders of the Medical Council and also State Medical Council saying MD medicine claiming himself to be physician cardiologist. इसे आप नहीं कर सकते. MD medicine saying physician diabetologist. सबसे बड़ी OPD physician general physician की है डायबिटीज की, much more than DM endocrinology. क्या करोगे जी? तो दिल्ली में चल रहा है. लेकिन अगर कोई बस्तर, आई एम टॉकिंग अबाउट स्मॉल टाउन्स जहाँ पे MBBS सब कुछ कर रहा है. Talk about rural surgeons, जहाँ पे कि I mean in army, I've been in the army, जहाँ जनरल सर्जन कोलिस फ्रैक्चर भी रिड्यूस करता है. Now, so what I am trying to say is that the picture is very fuzzy, but still there is compartmentalization. और आप जैसे जैसे एडिशनल क्वालिफिकेशन हासिल करते हैं, इनफैक्ट जिस सीनियरिटी के डॉक्टर ऋषि, मैं, डॉक्टर जग्गी और हम हैं, उस जमाने में एक बार आपने मेडिकल काउंसिल में MBBS रजिस्ट्रेशन कराया, थैंक यू वेरी मच. आप उसके बाद मेडिकल काउंसिल का मुंह भी नहीं देखते थे. आप कभी अपनी पोस्ट ग्रेजुएट क्वालिफिकेशन आपने शायद कई सालों तक दाखिल नहीं कराई होगी. ये अब थोड़ा सा माहौल बदला है. सो एनीवे, ये एक मैंने पर्सपेक्टिव आपके सामने रखा. बट now when it comes to Dr. Sudhi's question, we have to give an answer, and both Dr. Rishi and Dr. Jaggi have given an answer. So I am giving the same answer, that if you are qualified, you can do a procedure. If you are trained but not qualified, you can establish to any person questioning you कि आप ये क्यों कर रहे हैं, तो आप अपना लॉग दिखाएं, आप अपनी ट्रेनिंग दिखाएं कि साहब मेरा को ट्रेनिंग है इसलिए मैं इसको कर रहा हूँ. That is what will decide कि आप क्या कर सकते हैं. अगेन इंडिविजुअल केस टू केस है. आपको डिफेंड करना है अपने आप को या क्या करना है, देन वी विल टेक इट अकॉर्डिंगली. सो आई हैव ट्राइड टू एक्सप्लेन द पोजीशन which I have acquired, understood over these last several years of working in the medical, legal, medical negligence, medical counsel, etc. etc.
Can I add something here?
Please, sir, please.
So
I hope I have tried to say something.
Excellent,
Some
excellent.
of it may be very revolutionary.
Whatever you explain is very authoritative and very valid. So I want to say something. I was in a conference and I was hearing an authoritative person on medical law speaking. So he said that if you are an MBBS and you are doing a cesarean, nobody will question you. But if you have done MS general surgery and then you do a cesarean, you may be questioned. And if you have done now MCH in urology and then now you're doing a appendicectomy, you will be questioned. So as the more specialty you go, you narrow your field. But if you remain down, you are an MBBS, you can come out easily because you are trained in all 10 subjects and you can do gynecology, surgery, everything. Even if you could do a cataract also.
Okay. So regarding this, thank you very much for all your points. Two important questions. One, जितना मुझे समझ में आया वो ये कि these are not absolutely contraindicated. Depending, first of all, question arises when you have some complication. Question only arises that time. So if
Exactly.
someone is able to provide a safe surgical procedure to any patient, safe and a sound, a rational surgical procedure to any patient, usually the question never arises. कोई complication होता है and the person who is operating is not able to manage that complication because that person is not properly trained. Usually the question arises that time. So anyone who is not properly trained in particular procedure, that time that surgeon must take care कि whether if any complication which is always a possibility, तो क्या वो उसको defend कर सकता है कि नहीं, because then that person will be in suit. In any case, अगर कोई question arise होता है, if you are able to produce your log कि आपने ये procedure कर रखा है, you are relatively safe, बशर्ते कि आपका complication नहीं हुआ है and you are able to manage your complication अगर हुआ है. सर जगदी सर ने एक जो क्वेश्चन जो बताया, ये बहुत ही इंपॉर्टेंट क्वेश्चन था. इनफैक्ट आई वांटेड टू आस्क दिस कि जो हम हायर क्वालिफिकेशन अचीव करते हैं, तो क्या ये एडिशनल क्वालिफिकेशन है या कि हम एमबीबीएस का काम भी कर सकते हैं, हम एमएस का काम भी कर सकते हैं, हम एमसीएच का भी काम अच्छे से कर सकते हैं, या ये एक बार हो गया, एक ऑब्स्टेकल हो गया कि अब बस अगर हम एमसीएच हो गए तो हम कोलिसिस्टेक्टमी नहीं कर सकते. अगर कोई एंडोक्रिन सर्जन है तो वो कोलिसिस्टेक्टमी नहीं कर सकता है, या वो कोलिसिस्टेक्टमी भी कर सकता है और थायराइड भी बहुत अच्छे से कर सकता है. तो इन दोनों में फर्क है. सो दिस आई अभी जब ये क्वेश्चन उठाई है तो इसमें भी एक प्रकाश डाल दीजिए कि वो बिल्कुल कर ही नहीं सकता. अगर उसने कोलिसिस्टेक्टमी कर दी तो उसके ऊपर केस हो सकता है, या फिर वो कोलिसिस्टेक्टमी भी कर सकता है क्योंकि उसने 3 साल एमएस जनरल सर्जरी को दिए हैं, अच्छी सी ट्रेनिंग की है. अब उसने एक एडिशनल क्वालिफिकेशन भी अचीव की है जिसमें कि वो ब्रेस्ट एंड एंडोक्रिन सर्जरी कर रहा है. वो डिपेंड करता है कि उसके हालात कहाँ हैं. जहाँ पेशेंट नहीं होगा तो वो जनरल सर्जरी के पेशेंट से अपना चलाएगा.
Such cases have gone to the court of the law. ऐसा हुआ है, where they have been sued, and whatever you are saying, they have said the same thing and they have bailed out themselves. But MCI regulations say that if you are trained in a particular field, you have to now carry on the work in that field.
So there is a MS general surgery that person is trained into. So he has a sound knowledge of general surgery, as well as now he is specialized, so provide specialized care to other. So this is an additional qualification, if I am not wrong, rather than कि अब वो जनरल सर्जरी नहीं कर सकता. अब ये बात अलग है कि उसके पास ब्रेस्ट एंडोक्रिन के पेशेंट नहीं होंगे तो वो जनरल सर्जरी से काम चलाएगा ऑब्वियसली, लेकिन वो क्या उसके लिए एकदम बार हो गया कि नहीं हो गया. That's it.
Oh, that is the same thing why a surgeon cannot do a cesarean, or why he cannot do a hysterectomy. So these things, if you are in a soup, if you are in any litigation, this is how you prove yourself out of that. So you need resistance of people like Dr. Sunil Khatri. They'll bail you out.
Yeah, thank you very much. So now we move on to our next question, that is overseas qualification versus MCI. So this is a very interesting problem that I'm putting. Dr. Endo, who is an MCH in endocrine surgery, went to Taiwan to learn and upskill himself in robotic thyroidectomy. Okay. Following 1 month of rigorous certificate training program, so he did a certificate training program with a robot trainers, and he observed the surgical skills ki how the Taiwanese surgeons were performing the robotic thyroidectomy, and he learned. Now he felt quite confident, and he planned to start the similar technique in India at his center where the robotic surgery is available. Unfortunately, during his initial cases only, he had a recurrent laryngeal nerve paralysis and permanent hypocalcemia while operating on a small solitary thyroid nodule in a 20-year-old unmarried female. तो उनसे कॉम्प्लिकेशन हो गया, छोटे से थायराइड नोड्यूल में रिकरेंट लैरिंजियल नर्व पैरालिसिस होगी बिकॉज ही वाज अंडर हिज दिस ट्रेनिंग पीरियड. एक तरह से देखा जाए तो उनका जो शुरुआती पीरियड होता है उसको हम बोलते हैं लर्निंग कर्व के दौरान. अभी सिमिलरली एक डॉक्टर ब्रेस्ट हैं, उन्होंने फॉलोइंग हर MS जनरल सर्जरी वेंट and did a 3-year rigorous online training program, एक University of East Anglia UK से, MCH in oncoplastic breast surgery. Following the completion of her training, she started practice and did couples of oncoplastic breast surgery. However, in one of her breast reconstruction, the symmetry was not up to the satisfaction. Patient की satisfaction के अनुरूप नहीं थी वो. अब क्वेश्चन है if the can the patient complain regarding incompetency against the surgeon and false advertise of an MCI non-recognized degree? Can the surgeon defend? Because these both the degrees were from foreign countries. And how recognized are these degrees and certificates? क्योंकि बहुत सारी जो new techniques आती हैं ये foreign countries से आती हैं. तो अगर हम उनको यहाँ इंडिया में लाना चाहते हैं, most of the time we have to go to some foreign country, learn that technique, get some certificate from them कि अच्छा हमने आपको observe किया, हमने train अपने आप को train किया, and then we practice here. So suppose if any complication happens, so are these degrees somewhere recognized, और क्या हम उसको defend कर सकते हैं कि नहीं हम तो वहाँ गए थे, हमने वहाँ पे degree achieve? Sir, your opinions.
Should I speak?
Yes, sir.
Okay. Whatever little knowledge I have, I think a person who is trained from a center of repute, which can easily be established, how much work is being done in that center, how much training is essential for a person to have to become a practitioner for that particular field, and after say returning to India, how much experience he has gained, how many cases he has done. Supposing he is doing his first case and he creates a disaster, so he will definitely be punished. But if he has done series of cases and he has been successful, and once something goes wrong, he may be held liable, but still his intention is not wrong. So if he proves that he tried his best, but still the results were not up to the expectations, so there are ample number of cases where court says the doctor, if he has given a proper treatment and the court finds that the result was not desired, the patient had a mortality or any say a disability, the court exonerates the doctor. Dr. Khatri.
Yeah, thank you very much. So absolutely right. Firstly, the first question Dr. Sudhi said, are these qualifications recognized? The answer is no, they are not recognized. And I'll give you with examples also after. Insofar as the second part is concerned, if they can reasonably establish their training, their credentials, what they have, first is you observe, then you assist, then they assist you. This is the way the learning curve is insofar as surgical disciplines is concerned. So he should be able to establish reasonably that what he has learned, how he has learned, and what has been the pattern of his learning. Recurrent laryngeal nerve injury is a known complication after that. So if he has been able to establish that he has been adequately trained and this is a known complication, I think he is exonerated. However, as I have said repeatedly in my presentation, thou shalt cause no harm. I'll give you an example of a 5-year-old child who was low birth and had a ventricular septal defect. This was son of a Indian origin lady who was married to a Angrez in South Africa. They came to India to a corporate hospital in Delhi. The standard of care says that if the birth weight is X kg, I think less than 6 kgs, you don't go for surgery at that time. You wait for the child to grow and then you operate. Unfortunately, came the situation that the person was an MD in pediatrics, which is a purely non-surgical discipline. After his MD in pediatrics, he got trained in a corporate hospital in India in pediatric intervention cardiology, non-recognized qualification by MCI, only recognized by the national board. And he punctured all possible chambers and the little baby suffered irreversible brain damage, kidney damage, and the family was up for litigation. So what I'm trying to say is, qualification unrecognized, yes, unrecognized. Foreign quality, such training courses of 4 weeks, 8 weeks, 10 weeks, etc. In most of these training, you are not allowed to touch patients. But if you can establish that the training curve was such that first you observed, then you assisted, then they assisted you, and you have done as many number of cases, and the complication is a known complication like a recurrent laryngeal nerve injury, then you may be able to save yourself. But please remember that don't be over aggressive, be kind to the patient. Follow that, do I know, would I do it to my own relative? Just follow that guiding principle to your own consciousness and then only operate. I just submit this only.
Yes, sir.
So again, say facts of the case, circumstances of the case are more important than some straitjacket solution.
Yes, sir. Now Rishi sir would like to add something, sir. Do you agree with both the panelists, or would be like, are you differ in some point?
Yes, I agree with both the comments, both sides, but there should be documentation to present in the court. Court rely only on the documentation. So documentation or your experience, your qualification, that should be very well saved and that will be presented in the court. Only then you will be exonerated.
Fine. So the take-home message for all our participants, important is, again, the question arises when you suffer, when you come across any complication. So once you pass out from an institute, it is very difficult that you get this type of exposure of observation, then you assist, and then you are being assessed, and then you operate independently. Once you are out from an institute, you received your degree, then this opportunity is absolutely lost. Once you are in a practice, then anyhow you have to now survive on your own. The the advancements are too rapid. You are ambitious, you want to learn new technique, but now you are into practice. So even if you receive any certificate degree from any institute, be it in India or from across, be vigilant about, don't cause any harm to the patient, go slow, be safe, explain everything to the patient, be ready for strategy change in case you feel you are not able to achieve good result, health is in compromise. Don't hesitate in converting, and like accept your mistake and try to have a consistent correlation relationship with the patient. Don't lose your rapport with the patient, so that the patient know that you are with the patient in the times of complication. And these are different methods you can tide over gradually, and gradually when you keep on doing your cases, your experiences will grow. So be safe, be slow. Patient safety must not compromise, and you will gradually pick up the learning curve, if I'm not wrong. Yeah.
I wish to make a submission with the permission.
Yes, sir.
I want to give you an example of how important it is to accept a complication or a negligence even and be, in communication with the patient. In a hospital in Delhi, a general surgeon was operating upon umbilical hernia. A preoperative ultrasound had been done as a routine. And it was documented that the patient has solitary ectopic kidney. This man was very aggressive. He put his hand inside and felt a mass. Histopathology eye, kidney, normal kidney tissue, no other kidney. You know what the surgeon did? He informed the husband of the lady और उसके पैर पकड़ लिए उसने कहा गलती होगी मुझसे. And this surgeon held hands of the patient till a kidney transplant was done at the All India Institute of Medical Sciences. No case was filed against this surgeon. These are just examples I'm giving you that in spite of such a major disaster, you communicate with the patient, acknowledge the wrong, and say that I am holding your hands. Now it is the patient's goodness that nothing was done. So anyway, some incidents which I remembered, I thought I'll probably place before
That
this.
was a very nice incidents that you shared with us, and it is really helpful to develop a new insights. Now we move on to our next problem, that is the lack of newer techniques. So this is very interesting. So there is a case of a 45-year-old singer who underwent surgery by a reputed endocrine surgeon. Lack of newer techniques. So what is this problem? 45-year-old singer underwent surgery by a reputed endocrine surgeon of the city for a multinodular goiter. Because the tumor was very vascular and there was some altered anatomy, the right recurrent laryngeal nerve got severely injured. And post-operatively, he developed prolonged hoarseness, compromising professional life. There was no intraoperative neuromonitor used due to availability issue and cost factors towards the patient. Now, there is another case, a 36-year-old female with an early breast cancer who consulted a breast surgeon. She underwent left-sided modified radical mastectomy. Histopathology showed no axillary lymph node positivity. Post-operatively, because of that axillary clearance, she had a debilitating left upper limb lymphedema. Again, there was no intraoperative frozen section biopsy done because it was not available. A cost factor, lack of validation study with the team. So the question is, okay, so there is another question, sir. A 39-year-old female with primary hyperparathyroidism, right inferior parathyroid confirm हुआ, concomitant था दो images में, अल्ट्रासाउंड में और में भी स्कैन में. प्री ऑपरेटिव कैल्शियम 11 था, अंडरवेंट 391 था प्री ऑपरेटिव कैल्शियम, और अंडरवेंट बायलेटरल नेक एक्सप्लोरेशन विद एक्सीजन ऑफ डिजीज ग्लैंड. लेकिन जब पोस्ट ऑपरेटिव कैल्शियम है वो अराउंड 100 to 125, इट रिमेन्ड हाई. So there was a slight change in parathyroid hormone, but it still remained high. अब इंट्रा PTH यूज नहीं हुआ because of lack of availability and high cost. Now the question is, अब ये जो newer modalities हैं, are these must? How to decide if they are the standard of care? Because not all places have equal opportunities and facilities. And how can the surgeon defend themselves without giving up these procedures? Can someone say कि आपके पास ये technique नहीं है, इसलिए you are not eligible to perform these procedures? And suppose if complication happens, you are not able to defend. So what is your take on that? Yes, sir. Rishi sir, Jaggi sir.
I'll come out. So can you come to the first question?
Sir, ये
first आपकी first slide जो थी.
Yes sir. हमने first slide
case one
इंट्रा ऑफ न्यूरो मॉनिटर को लेके.
हाँ. So it is a well-known fact that in all thyroid surgeries you have recurrent laryngeal nerve injury in 1% of the cases. This has been established. So the court has to be told कि ये ऐसा हो जाता है. Number one. So we should also know, the doctor should be knowing that recurrent laryngeal nerve can be injured. If can be injured, then what should we do? We should have a pre-operative laryngoscopy, post-operative laryngoscopy, intra-operative monitoring of the recurrent laryngeal nerve by that monitoring probe, neuroprobe. So these should be available, but that doesn't mean that in Saharanpur nobody can do a thyroid. So our country doesn't have such facilities or such hospitals everywhere. So the courts have to be lenient on this. ऐसा नहीं है. Even in Meerut, I don't think, I don't know about your setup, but any other setup would be having a neuro monitoring device. Similarly, as far as intra-operative estimation of parathormone, so this is not available everywhere. Frozen section is not available everywhere. A recent judgment of, say, I think recent in 2023 of a case which started in 2007, where a lady went to a general surgeon for a breast lump. He excised that lump. The histopathology came plus minus malignancy and phylloides tumor. The surgeon referred this case to a specialist in a, say, I can tell you, King George's Medical University. The patient from a small town nearby Lucknow went to King George's Medical University, where the surgeon saw it, and ultimately the patient was referred and the patient was given chemotherapy. Patient received chemotherapy, and after 1 month she had bad effects of chemotherapy. She lost her hair and other vomitings and all that. Then she went to a super specialist. Then the whole thing was reviewed and it was found that the lesion was benign. And the doctor there, KGMU, has been punished, I think 4.5 lakhs or even more. This is the very recent judgment, I think, of August. So things happen, and how the court takes the, and how you defend, everything depends on that.
Okay, Rishi sir, Sunil sir.
I will request for a repeat of the question.
सर ये मेरा क्वेश्चन है, जो आपने एक बताया कि जो रीसेंट एडवांसमेंट्स बहुत है और हमारे जो लॉज एंड एथिक्स है अभी उसको कैचअप नहीं कर पा रहे, सो व्हाट इज योर टेक कि अब जो न्यूअर मोडालिटीज आ रही हैं लाइक इंट्राऑपरेटिव पीटीएच है, इंट्राऑपरेटिव न्यूरो मॉनिटरिंग है, दीज आर कॉस्टली इन्वेस्टिगेशंस
फ्रोजन
बट
सेक्शन है,
not readily available everywhere because of cost issue, availability, expertise, everything. So are these like the surgeons who are endocrine surgeons or breast surgeons who are performing these cases, they must stop doing performing these procedures कि अगर कुछ उसमें रेसिडुअल डिजीज रह गई या कुछ भी कॉम्प्लिकेशन हुआ तो पेशेंट में से कि अच्छा आपने ये यूज नहीं किया था, हमको हायर सेंटर रेफर नहीं किया, तो इसीलिए हम ये वी आर नॉट एलिजिबल बिकॉज वी डोंट हैव दीज न्यू टेक्निक्स. और
मतलब let us come back to the same thing, where you are doing the procedure, is it available in your city? क्या मेरठ में फ्रोजन अवेलेबल है या नहीं है? यदि है आप उसको करिए. Please inform the patient. Even if there are cost issues involved, you inform the patient. If the patient declines, but everything has to be based on information, patient information, because the patient has the right to choose, and you have to inform about the safety. That if I do this monitoring intraoperatively, आपकी सेफ्टी इसमें बढ़ जाएगी, लेकिन इसमें इतना खर्चा और आएगा. So as a part of the informed consent, you are obliged to mention this to the patient. If the patient declines, you have, de-risked yourself. If the patient accepts it, please go ahead with it. But I would say that performing frozen section is probably an order of the day when you are thinking of malignancy. So वो उसको deny करना would not be fair if the facilities are available in a particular city. So it all depends where you are located and what facilities are available to you, and what is the emergency nature of the surgery. Is it a planned surgery or is it an emergency surgery in which you are undertaking life saving situations? So this is what we will determine.
Dr. Khatri, हमें ये बताइए, a person in Muzaffarnagar is doing a thyroid surgery.
जी.
He is very well trained in thyroid. He has a thesis of MS on thyroid.
जी.
But he doesn't have that neuro monitoring probe.
जी.
तो क्या वो सर्जरी करनी वहां छोड़ दे?
ना, बिल्कुल नहीं छोड़ेगा, बिल्कुल वो करेगा. मैंने वो आपसे
उसने मरीज को बताया कि तुम्हारी सेफ्टी जो है कॉम्प्रोमाइज हो रही है भाई.
नहीं, लेकिन अगर वो
कराएगा ही नहीं फिर सर्जरी.
नहीं डॉक्टर जगी, अगर वो फैसिलिटी मुजफ्फरनगर में अवेलेबल ही नहीं है and he doesn't have to refer the patient to Delhi in one center where this facility may be available. He has to do it in Muzaffarnagar if the facility is not available, and recurrent laryngeal nerve injury or an injury to the parathyroid gland, that I don't know the statistics. What are the statistics of parathyroid injury? I don't recall, but I definitely recall from my general surgical days that you tie the ligature close to the thyroid, the recurrent laryngeal nerve is safe, and if yet the recurrent laryngeal nerve injury takes place, you are safeguarded. And as was rightly pointed out, that before the surgery, please do a laryngoscopy, see both the vocal cords are moving, which means your recurrent laryngeal nerve is intact. And after the surgery is over, please request the anesthetist, document what the status is, and thank you very much. So no worries at all. हम काम करना नहीं छोड़ेंगे, और ना ही कानून हमसे ये उम्मीद करता है कि हम काम करना छोड़ दें, क्योंकि हम उसके लिए ट्रेंड है. हम समाज, एक्चुअली वी आर सर्विंग दिस सोसाइटी बाय परफॉर्मिंग these procedures in Muzaffarnagar or Bagpat or wherever the case may be. But I am just saying that we don't have to be so worried about medical litigation. Costs of healthcare have risen, but at the same time, the courts and the system is not so bad that if somebody has done a reasonable job and has done with his best intention, things should go right. इतना परेशान होने की आवश्यकता है नहीं डॉक्टर्स को. यदि मर भी जाएगा पेशेंट, डेथ पीपल विल डाई इन हॉस्पिटल्स ओनली, दे विल नॉट डाई ऑन क्रिकेट फील्ड्स, दे विल डाई इन हॉस्पिटल्स.
एक छोटा सा डेटा देता हूँ
जी.
जितनी भी लिटिगेशंस हुई हैं थायराइड के नर्व इंजरीज पे, रिकरेंट लैरिंजियल नर्व इंजरीज में, तो उसमें मतलब थायराइड पे जितनी भी हुई हैं 51% रिकरेंट लैरिंजियल नर्व इंजरी वाली है
जी.
और उसमें से 1/3 डॉक्टर्स जो थे वो पेनलाइज हुए हैं.
अच्छा, ओह माय गॉड.
ये डेटा अवेलेबल है नेट में.
ओके,
तो मैं आई जस्ट वांटेड टू शेयर है.
नहीं, थैंक यू वेरी मच फॉर शेयरिंग.
ठीक है
सर. ऋषि सर वांट टू ऐड समथिंग सर?
Yes, yes. I have to add that all these information should be made part of informed consent. Whenever you take consent, give it clearly that I have these facilities, I don't have these facilities, and there are so much complications without this facility. So we give it opportunity to the patient to give informed consent, giving all the informations submitted in that informed consent in writing.
Fine, sir. You made a very valid point. Important is कि whatsoever facilities you have, just inform the patient कि with these facilities your cost will be like this. Give all the options available to the patient and let the patient decide कि कैसे करना है. काम करना छोड़ना नहीं है. जो भी आपने अपने MS days से MCH days से सीखा है, please continue doing that. Try to incorporate those facilities at your center if the condition permits you. But if अगर वो आपके पास फैसिलिटी नहीं है तो यू कैन बट टेक एन इन्फॉर्म्ड कंसेंट कि भैया ऐसा ऐसा हो सकता है सो दैट यू आर सेफ फ्रॉम द लिटिगेशंस. सो आई होप फ्रेंड्स दिस पॉइंट इज नाउ क्लियर टू यू ऑल. नाउ अनदर क्वेश्चन, दिस इज वेरी इंपॉर्टेंट, दैट इज मिस्ड डायग्नोसिस. So this diagnosis is of like suppose a case 40-year-old female gynecologist के पास गए for routine breast evaluation and screening. Clinical examination unremarkable था. Screening mammography was reported as normal and patient was reassured. 1 year later, she presented to a tertiary care referral center with a palpable malignant lump with distant metastasis. अब जब उन्होंने 1 साल पुराना मैमोग्राफी री-इवेल्युएट किया, then they found that there was a missed malignant lesion in the previous mammography. Similarly, a 46-year-old premenopausal lady presented to a general surgeon with a 1 × 1 centimeter palpable breast lump. और उसके साथ उसको adjoining single duct bloody nipple discharge था. For single duct bloody nipple discharge, she underwent micrododectomy with breast lump excision. Pathology report was intraductal papilloma. Patient was reassured with regular follow-up. She developed recurrent breast lump after 1 year, and she was then worked up by a breast surgeon, and it was reported as invasive ductal carcinoma. प्रीवियस हिस्टोपैथोलॉजी रिपोर्ट को जब रिव्यू किया गया तो देखा गया कि उसमें भी इन्वेजिव कार्सिनोमा था विच वाज मिस्ड इन द इनिशियल रिपोर्ट. तो पहली जो रिपोर्ट थी उसमें कैंसर, इन्वेजिव कैंसर को मिस किया गया. नाउ द क्वेश्चन इज व्हाट आर द इम्प्लीकेशन ऑफ मिस्ड डायग्नोसिस ऑन एनी पैथोलॉजिस्ट एंड रेडियोलॉजिस्ट? आर दे एग्जेम्प्ट फॉर इट? दे मस्ट नाउ रिगरसली लुकिंग फॉर दिस लीजन, और उनको थोड़ा सा एक मार्जिन है कि लाइक दे कैन बी एग्जेम्प्ट. व्हाट आर द रेमेडियल मेजर्स of a missed diagnosis?
Yeah, okay, I'll take this up. The mammogram decision, I mean, based on a mammogram to say there is no malignancy is not fair to the patient. It is a tissue diagnosis which should be established in a breast lump. A negative, more negatives are to the safety of the patient, but missing out is definitely amounts to negligence. Second point, insofar as pathologist's review of slide is concerned, it is not an emergency plan that he has to give a report within 5 minutes. If he is missing it, he definitely has to be penalized for it. So he has no margin of safety on this, unless the tissue itself is such that it is not showing evidence of malignancy in the blocks and slides which have been presented to him. So one is clinical, second is where the tissue was taken from. If the block and slide are giving evidence of malignancy on histology, then the pathologist has no margin of permission of error, because there is nothing like intent or a judgment. He has to give a judgment because that is the final court of appeal insofar as the clinician's decision further is concerned. That is my say.
Okay, sir. Rishi sir and Jackie sir would like to add something.
The scenario which you have presented, Dr. Sudhi, is it a true case in which the mammogram said normal and 1 year back it was reviewed?
Yes, sir, certainly.
Or it is just an imaginary scenario?
First of all, sir, I would like to say that these are the true case scenarios that we often see. We see such cases. It is unfortunate, but it is true. So and not only you may not believe, I have come across a case where I have operated a breast cancer And as such, I advise that patient for a PET scan because of the breast cancer for metastatic workup. That patient went to some other, and I said, ki if there is some monetary issue, you can go for an ultrasound abdomen and chest X-ray, as what we usually ask for a low socioeconomic patient. So that usually I have a team in which we get all the investigation done, where we have a close collaboration. Unfortunately, that patient went to some other radiologist, where that patient had ultrasound done by some other person, so which came out to be a normal report. Patient presented to me. I said, okay, all your reports are normal. Based on these reports, I operated the patient. Within 1 to 2 weeks of primary surgery, that patient presented again with abdominal pain. So that pain was very severe, and the patient I had to admit in my under my care. And when I evaluated, I said, let's see the ultrasound report which this patient had before 10 to 20, 2 to 3 weeks before the surgery, recently. And then I repeated the ultrasound. So she had bilateral renal concretion. Not only that, she had around 20 centimeter of ovarian tumor. So the important point is how come any sonologist can miss 20 centimeter of ovarian tumor in abdomen on ultrasound?
Agreed.
It is very unfortunate. It is very unfortunate. And mammography is one such investigation which requires really a lot of expertise to read.
I was wondering that if that patient had only a mammogram done and she didn't have a lump in the breast, when why did she get a mammogram done? Did
Okay,
she
sir,
have a lump in the breast?
I tell you regarding this. Most of the time, when we do a mammography, requires a lot of expertise to read. So it requires a lot of expertise to detect microcalcification. Now is the time of screening era. So a patient present with apprehension of malignancy, and
Apprehension.
it is more of a challenge to us to label any subtle lesion whether it is malignant. So this challenge we are facing nowadays. So to detect a small lesion which may later on turn out to be malignant. So this is something. So if it is something like some radiologist is more expert in reading mammography, they will detect some small lesion. Some radiologist who is not that expert in reading the mammography may miss out the lesion. So it is a possibility, sir.
So that is no fault of the surgeon.
No
Fault?
fault on the
No,
surgeon.
no,
It is
no,
a
no
fault
fault of
of the radiologist,
the
whether they
radiologist.
missed or not.
So
If
now
they
newer techniques like MRI assisted mammogram.
But it depends, like whether the facility is available or whether it was advised or not. Most of the time, it is also the habit of the doctors. They don't see the images; they just read the report.
Very true.
Yes.
Very true.
So
I can give you
we
an
are
instance.
doctors, so we know the fallacies also. So
I,
here
I,
we are here to
I
discuss.
can give you an instance. I was called on the OT table to operate a gallbladder. When I reached the hospital, the patient was already anesthetized, painted, and draped, and the knife was ready. So I asked them to just put the ultrasound on the view box. And I saw the ultrasound, and the gallbladder had no stone. Two, three
Okay.
images were there and no stone. So I pointed out this thing, and I asked for a ultrasound in the operation theater. At that time, portable machines were allowed, and we got it done. I got an ultrasound done, and there was no stone. So ultimately, it was investigated, and what happened was that the typist, instead of writing "no stone seen," had typed "one stone seen."
So it happens, sir. It
It
happens, and
happens, huh?
this is unfortunate. And regarding pathology, also, you may not believe, because of these type of problems that we faced, my team, my pathologist provide me a printed histophotomicrograph of each and every histopathology report that she reports. Based on these images, she has reported this particular thing to me, so
Correct.
that I am doubly sure, and my pathologist is also sure that, like, my surgeon will ask. So we have this type of protocol with us, and because of this type of problem only, because what they have seen I cannot judge, and what they have seen with what is their expertise, that also I cannot compare. Yeah. So this is the something to safeguard myself, as well as to have a histophotomicrograph, so that we can later on audit and can do some studies also. But this is something to safeguard myself, because I was also fall trap of this type of scenario. So to save myself, I have to, so this is that's why I have put in this scenario in this forum, so that all any pathologist or radiologist in a group, they can sensitize themselves that they are also not exempt. They are liable for any litigation if anytime they miss any, so they have to be very vigilant while they do any sonography imaging reporting or pathology reporting.
Very correct. Very
Yes.
correct.
So Rishi sir, want to add something?
Rightly, you have commented that one should be vigilant while reporting. But
Hmm.
even in the hand of experts, there can be error. And in literature, what is the percentage of error? If it is in within that limit, documentation of that literature can save the reporter, whether it is ultrasound, whether it is a pathologist.
Yes, sir. So in this, I would like to make some concluding remark if you all agree. Uh, the, the radiology, pathology, and surgery, they are the three pillars. Like radiology, pathology, they are the important pillars of surgery or treatment of any patient. So there should be a close collaboration between the pathologist, radiologist, and surgeon. No one can work in isolation. They are the important pillars. So they must have a close collaboration. If they feel that they're not sure about the diagnosis, they can discuss with the surgeon, so that the surgeon convey this to the patient and can have second opinions as well. So again comes the safety of the patient must not compromise. The important lesson is this. Otherwise, we'll be in soup. Okay.
And the leader of the team, the captain of the ship, is the surgeon.
Yes.
So
Listen, I'm coming
the
to this point.
anesthetic is a support. So any mistake there, the courts tend to offer higher penalties. One, first to the hospital because they are supposed to have deeper pockets, and second to the surgeon because the surgeon is the captain of the team.
Yes, and I'm raising this question as well regarding our sixth problem-based learning, that is lack of service. So this is the something. What are the liabilities of anesthetist and surgeon during surgery, and what is the importance of monitoring? The reason I have put in this point, because this is the rising trend among the anesthetists, that as a surgeon I can appreciate that they induce the patient and they leave the patient in the OT, either sipping coffee in their doctor's lounge, or there is another deadly trend that is coming up. They induce multiple patients. If they get an opportunity to take up another case, they take another case also, multiple cases, at least 4 to 5 cases at a time. So is it logical? Is it ethical? Is it lawful? Or there are some liabilities of surgeon and anesthetist? Is the monitoring not required? It is not important.
It is extremely important. One, anesthetist should start a case, monitor the case, extubate, and then conclude. He should not do multiple patients at the same time. It is compromising with the patient safety. And fortunately, anesthesia is a very dependent specialty upon the surgeon. So surgeon should command, he should demand that Mr. So-and-so, you are getting revenue from me. Please look at my patient's safety. I demand this from you. And let them not be using you as a tool for enhancing their revenue. Please tell them patient safety is most important, because in an unfortunate event, it is not only the anesthetist who will become liable, it is you also who will become liable. And anesthesia is such a bloody pathetic specialty at times. I'll give you an example. I came across a doctor who got 250 rupees for giving anesthesia, spinal anesthesia for a cesarean in Lucknow maybe 20 years ago. He got adverse order against him. The center was ill equipped. The patient had very, very bad complication. For that 250 rupees, he compromised with the safety of the patient and landed up in such difficulty that large compensations were awarded against him. He had an adverse judgment from district commission. He had adverse judgment from the state commission. He came to me for appeal in national commission. And I am not crazy for looking for cases. I said, thank you very much. You have hardly any case. Please pay the compensation and get out of it. That's when he shared with me. He got 250 rupees for giving the spinal anesthesia some 10, 15 years ago or so. So coming back to the main point, please, as a surgeon, as a hospital head, see to it that the patient safety is not compromised by such anesthesiologists who try to induce multiple patients, and they land up the patient in mess. I have a patient, a family whose mother had a bilateral TKR. They had hypotension during anesthesia, during surgery, and within 12 hours of surgery, the patient went into renal shutdown, lived for 50 days. All sorts of complications happened. 50 lakh का bill हुआ, dead body हाथ में आए. All because the anesthetist was doing multiple cases at the same time and was not monitoring the patient. वो बैग पकड़ा के चला गया अपने assistant को, and that's it.
So just 2 minutes if you can, so that we can conclude in a proper way. We have almost finished up with almost everything, almost all the questions. Last question on consent was pending, but maybe we may take some other session.
Just 1 minute. Huh?
We have almost covered everything, and I'm so excited. We exhaustively discussed about each and every point, and though we have run out of time, but still we have made everything possible, all the points that we wanted to discuss. So by the time Sunil sir is joining, may I ask Jaggi sir and Rishi sir to make some concluding remark, how they like the program, anything they wish us to modify so that we can be more informative, more learning we can include in our program, or what is their experience. And after that, we'll have some concluding remarks from Sunil sir, and then we will wind up today's meeting. So Jaggi sir, would you like to say something about our team?
That was great to have been a part of this wonderful webinar. And Dr. Sunil Khatri, I really admire his knowledge and the way he delivers his points. And I thank him from the core of my heart for really.
Thank you very much. I am
enlightening us. Thank you, sir. Thank you so much. You are back on the screen.
Thank you very much.
Thank you so much.
All the panelists, Dr. Rishi, Dr. Jaggi, Dr. Sudhi, for organizing such a wonderful, webinar, and I be a part of it. It is just my circumstances that I had to, towards the end of it, request you for.
No, sir, and you gave your precious time. I'm so thankful. So, Rishi sir, would you like to say something?
Dr. Sunil is really an asset for our medical profession, that he used to defend the doctors in any court. So it was a wonderful interaction, and we gained much more knowledge from Dr. Sunil, and hope that he will continue to support the doctor, and such webinars will be repeatedly done by Dr. Sudhi, and advancing the knowledge to the fraternity on medical legal field. Thank you very much.
Thank you very much, respected all. Thank you for your time. And for those who practice breast surgery, I request you all, please save your last Friday of October for sure for a breast meet, because in October we have lots of breast related activities, and in that we will be take that advantage opportunity to discuss about the how to work up any patient with suspected genetic breast cancer. So what are the various points, and we have experts to deliver knowledge for the topic. And save your date and time. The details I will be sharing soon. Today's meeting is we have recorded, and it will be soon uploaded on YouTube. The link will be shared for all those who have not attended or has to leave the meeting in between. Anytime they can come to visit our program again and can enlighten themselves. Sir, if you can ask.
I have one final message, if I may be allowed to do so.
Sure, sir. Sure.
One final message.
Please.
Patient safety is of paramount importance. Please, at all times, guide your, colleagues that they should be always very careful. Never compromise with patient safety at all.
And so one thing more I can understand is, even if the patient safety is compromised due to any reason, whenever any surgery or anesthesia is induced, the chances of complications increases every time. So even if it happens, always be compassionate and continue your rapport with the patient and the family, so that you don't, whenever this rapport is lost, then if every complication, even a minor complication, we as a surgeon, as a clinicians are in suit. So always develop a rapport. Always be ready to accept your mistake and try to rectify it. मतलब अगर जो भी ठीक हो सकता है उसको ठीक करने में भी कोई हर्ज नहीं, और अपने पेशेंट के साथ, अटेंडेंट के साथ हमेशा अच्छा रिश्ता बना के रखो। तो अगर कोई कॉम्प्लिकेशन होता भी है तो काफी चांसेस है कि आप उससे बाहर आ सकते हो आराम से।
And you be the first one to inform. One should not huddle up. If there is a mishap, you should be the first one to inform कि ऐसा कभी कभी हो जाता है, आमतौर पे नहीं होता बट ऐसा हो जाता है,
और जो भी रेमेडियल मेजर्स प्रोवाइड कर सकते हैं तो वो प्रोवाइड हो जाए बिल्कुल। तो आई होप फ्रेंड्स आज के हमारे सेमिनार से, वेबिनार से आप लोगों को काफी फायदा मिला होगा। आप लोगों ने बहुत सारे पॉइंट सीखे होंगे। हमारा कंसेंट प्रोसेस थोड़ा सा रह गया, जिसमें कि कंसेंट कैसे सही तरीके से लेना चाहिए। अगर सर 2 मिनट अगर आप लास्ट इसके बारे में और बता दें। सर जो मैं करती हूँ, मैं वीडियो कंसेंट लेती हूँ, और
नहीं वो तो ठीक है, लेकिन मोस्ट इम्पोर्टेंट इज प्रोसीजर स्पेसिफिक कंसेंट होना चाहिए। एक जनरल कंसेंट लेने की जो आदत है उसको छोड़ देना पड़ेगा और इन्फॉर्म्ड कंसेंट की तरफ बढ़ना पड़ेगा, और हर चीज लिख देनी पड़ेगी कि इस लैंग्वेज में, और उसका विटनेस होना चाहिए। अक्सर क्या होता है ना, डॉक्टर नहीं साइन करता बाद में कंसेंट, और फिर वो डॉक्यूमेंट डिलीवर हो जाते हैं मिसहैप के बाद, और फिर होता है कि साहब कंसेंट तो कंप्लीट थी ही नहीं।
कंसेंट पे अलग वेबिनार कर लीजिए कभी।
हाँ सर, उस पे कभी अलग से कर लेंगे।
अभी डॉक्टर खत्री को जाना है,
इजाजत ले लूं?
प्लीज, आई कैन सी
रिक्वेस्ट करूंगी, आप लोग भी अब इस मीटिंग को लीव कर सकते हैं। थैंक यू वेरी मच। हम अगली दोबारा मिलेंगे।